Let's welcome Dr. Ashok from Precise for his talk on ROP screening. Thank you.
Yeah, thank you, Dr. Anita. Thank you, KSOS, for giving this opportunity. The talk is basically about a precious preterm baby and how to go about ROP screening. Now, why we should go for ROP screening is because ROP is a potentially blinding disease, and it usually affects the preterm, born 4 or more weeks preterm, and has had a very adverse neonatal course. Okay, so when we talk about ROP, we talk about what is called a sight-threatening ROP. And we have the Rashtriya Bal Suraksha Karikram. Now, ROP is part of our child welfare program, and it has been intensively been taken up by the government of India. So that is the importance that ROP is being given now. Now we have the National ROP Task Force and our ROP operational guidelines. So this enumerates certain risk factors. The most important risk factor is preterm birth, exposure to excessive oxygen, sepsis, intraventricular hemorrhage, respiratory distress, failure to gain weight, blood transfusion. So this importance is failure to gain weight. So even if the birth weight is relatively normal, in the first few weeks the weight gain is not adequate. That itself is a risk factor for ROP. Now, whom to screen? This is the national guidelines, what I'm talking to you. Gestational age of 34 weeks or less, gestational age of more than 34 weeks if exposed to risk factors. Those are the risk factors I talked to you before. And if the gestational age is not known, birth weight of 2000 grams or less, other preterm infants at the discretion of the neonatologist. So practically, whenever you have a doubt that the baby can have ROP, you should screen. It's not that, birth weight or something. So importance should be given to gestational age at birth. Now, if the gestational age is not known, then comes birth weight. And then comes adverse neonatal course. And then comes, if the pediatrician feels that, the child is not okay, then it should be screened. So, the number of babies who are going to be excluded from ROP screening is becoming less and less and less. Now, when to screen? First screening should take place by 25 to 30 days of life. That is 4 to 6 weeks of birth. First screening should take place. Now, there is something called as a GROP guideline. So, this is applicable only to developed countries. So, we are a developing country. This applies to developed countries. And if they say if you follow this, there is a 100% strike rate of picking up ROP. So, what they talk about is birth weight of less than 1051 grams, gestational age of less than 28 weeks, 3 measures of slow postnatal weight gain. So, see, in developed countries, many of the birth weight is relatively high. And when they have a reduced weight gain less than what is expected, that itself is a risk factor for ROP and presence of hydrocephalus. So this they particularly say because the oxygen therapy in developed countries is very much, they give blended oxygen. That is, they don't give pure oxygen. It's a mix of normal air in the ICU and oxygen. So in developing countries like India, the oxygen concentration or the facility to give blended oxygen is very less. So that blended oxygen is a must in these guidelines. So in India, we don't give always blended oxygen. So GROP guidelines is not applicable to developing countries like India. Now, how do? You need to have a dilated exam. The concentration of tropicamide is 0.5%. And phenylephrine is 2.5%. So that is a mixture we give. And the baby should be fed at least 1 hour before the screening. And a trained nurse must monitor the vitals. So if the child is not really well, you have to go to the NICU and do the screening. If it's relatively stable, the child can be always brought to your OPD. But provided in the ideal situation, you should have a pulse oximeter or something connected, and somebody should be monitoring the vitals of the baby. Now, the basic thing of screening is whether the child has got a sight-threatening ROP or not. If a baby has got a sight-threatening ROP, it requires treatment. So, that is the basis of doing this screening. Then you have different things like zone, stage, extent and all that. Now the importance is zone and stage. Extent is number of clock hours. It's not much of importance in the present ROP screening. Now we have the IC14 guidelines, which are the new guidelines, which says new classification, which says posterior zone 2. That is a new concept that has been included. Then you have something called as a notch. Then you have incomplete vascularization. Now we talked about immature retina. Now it is called incomplete vascularization. Now earlier we have the aggressive posterior ROP. Now it is called aggressive ROP. Then we have stage 5. It is A and B. That is open funnel. That is a total retinal detachment, the end stage of ROP. Initially we had only open funnel RD and closed funnel RD. Now you have a classification called C also, which means there is an associated anterior segment changes. Now you have something called as a reactivated ROP. ROP which has regressed now has become active. Like in zone 2, the ROP has reactivated. So reactivated zone 2 ROP, like that. And FA and OCT has also been now included in the diagnosis and evaluation of ROP. So these are the new things that have come in the new IC ROP criteria. Now, the basis of this thing is there is an increasing recognition that ROP may occur even beyond the posterior retina, and we are now seeing larger preterm infants, and it is more common in developing nations with limited resources, like basically because of the oxygen concentration. Now we have 3 epidemics: the first epidemic, second epidemic, and the third epidemic of ROP. The first and third epidemics are almost similar because it is based on the kind of oxygen that is being delivered to babies. The second epidemic was due to early salvage of preterm infants. So that oxygen is the main thing that in developing countries, which is the issue. So posterior zone 2 means somewhere between zone 1 and zone 2, 2DD area, and it means more worrisome disease. Notch means the ROP has incurred in or encroached into a more posterior zone by 1 or 2 clock hours, and this means less worrisome disease, means a limited incursion into a more posterior zone. And the most important thing is plus and pre-plus disease. So when you're screening, when you see the posterior pole vessels are dilated and tortuous, that means the baby is going to have ROP. The importance is you don't even have to see the peripheral retina. You just see the posterior pole, dilated tortuous vessels, and engorgement of anterior segment iris vessels, and you know the baby has got plus disease. Plus disease means the child will have treatable ROP. So this is a photo of plus disease, just 2 minutes. And what kind of ROP you treat? According to the early treatment ROP trial, it is type 1 ROP. So any ROP with plus disease, you have to treat. Zone 1 ROPs, you have to treat. Then stage 2 or stage 3 ROPs, neither zone 1 or zone 2, you have to treat. So plus disease, plus disease, plus disease, that is the most important thing that you have to see while screening the baby. So zone 1 and 2 risky, plus disease risky. These are some of the photographs. How to assess the zones like central area zone 1, nasal aura up to the temporal periphery zone 2, and far temporal periphery is zone 3. So these are some of the things. And aggressive ROP, rapidly progressive ROP, it will not pass through the various stages of ROP because there will be incomplete vascularization of the zone 1 and zone 2. It will be flat. It will not be elevated like the usual ROP. You will feel it's immature retina, but it is very aggressive or advanced ROP. And unless it is treated within 24 to 48 hours, it will lead to permanent vision loss. So these are some of the things, and these are the complications of ROP. You can have RD, you can have, atrophic retina, myopia, all those things. And there is something called ROP-like retinopathy, which occurs in near-term infants. And they may be near normal birth weight. There are a lot of theories like, sudden decrease in blood flow, or a closure of the PDA or the foramen ovale, or the imbalance between the metabolic and nutritional need of the retina. All these things can lead to an ROP-like retinopathy even in term infants. Now, should we do universal screening? Now, there's been a study, they screened all babies, normal babies, and they found that 20% had retinal hemorrhages and 0.14% babies had ROP-like retinopathy. So, this is something to be pondered about. Other differential diagnoses like FEV or Coats disease also have to be kept in mind. Thank you very much.
Thank you very much, Dr. Ashok, for that wonderful talk on ROP and about the recent aspects of it.